Hi guys, we're going to talk about elimination today. And elimination really boils down to more than one thing when it comes to urine output. It could be a kidney issue and we are not producing enough urine. It could be a bladder issue. The bladder has the urine, the body's producing the urine, but it's not excreting it or having it come out. When we focus on elimination, we have to look at several factors and what truly may be going on and how can we find a solution for our patients that is sensitive to those needs. So let's get started here. When we look at each of these organs within the urinary system, we know each of these do, but we know what each of these do, but let's review each of them. We know that urinary elimination depends on the kidneys, the ureters, the bladder, and their urethra. The kidneys start by removing the waste from the blood to form urine. The ureters transport that urine from the kidney to the bladder. The bladder holds the urine until you have that urge to eliminate it. Our body holds anywhere from 600 to 1,000 mils of urine at any given time. But our body will give us a signal around 250 mils that says, you may need to go. That signal comes from the bladder, but goes to the micturition area inside of the spinal cord and sends that signal up saying, I need to go to the bathroom. Once we get that signal, the urine leaves the body through the urethra. So you can see that all these organs must work together for that patient to eliminate waste from their body. We have talked a little bit about this. This is when we go to the bathroom. Remember, that's a voluntary control. Urine is voluntary. We have an external sphincter. We control that sphincter and we can allow ourselves to go to the bathroom. There is a stretching of that bladder wall. When that wall is stretched, then that signal is sent to the micturition center. Then the signal goes to the brain and we can choose to ignore that urge or we can head to the restroom. We go to the bathroom, the external sphincter relaxes, and we urinate. Some of the problems that we will discuss have to do with that external sphincter. Most patients get a signal to go to the bathroom every 2 to 4 hours. However, this is going to depend on how much that patient's drinking and making sure we're asking those questions when we're doing our assessment. So what are some factors that might influence our urination? The ATI book lists these, and I just want you to understand each of these. Age, as the patient gets older, they have physiological changes that increase that risk for incontinence. They lose control of that external sphincter. Pregnancy causes increased abdominal pressure that may overcome the ability of that external sphincter to control, and they can lose control or be incontinent. Your diet is a factor. What you eat affects your urination. Artificial sweeteners or diet drinks can increase that incontinence. Patients that are immobile or on bed rest may have increase of urinary stasis. Surgical procedures or anesthesia can cause urinary problems. Anesthesia can cause a decreased reflux, so they don't have that urge to urinate or they have less control over that sphincter. Pain is definitely a factor. Medications can be a factor, especially our diuretics. They're going to increase the amount of urine that it's produced. Anticholinergics, tricyclic antidepressants are other medications that will increase that urine production. Psychological factors, anxiety, emotional stress, privacy. We take them to the bathroom, and if we're just staring at them, that's going to be a little bit of a factor, right? We have to stay because maybe they're a fall risk, but think about that psychological impact that puts on the patient. Fluid balance, so just know this different terminology. Nocturia means you're awakening at night to go to the urination. Awakening greater than one time in the night, right? Sometimes we all go during the night, but if you're going multiple times, that's nocturia. Polyuria is just an excessive amount of urine. Oliguria is that decrease in urine output regardless of how much we drink. Anuria, kidneys produce no urine. So we're in kidney failure, maybe dialysis. Diuresis is that increased formation of urine. And then fever is that increased body metabolism. Increased waste, more concentrated, it's going to cause our body to lose more fluid other ways like breathing, sweating, so we may have a decrease in our urine amount. So let's just look at some basic terminology. We've probably hit on a few of these already. When we think about urgency, that's that sudden, compelling urge to urinate. Some people will have that urge even with small amounts of urine. Dysuria is that painful or difficult urination. Oliguria is urine output less than 400 mils in a 24 hours, so it's less urine. Remember, our average adult urinates about 2,500 mils of urine in about 24-hour period of time. Polyuria is lots of urine. You're going to excrete more than 3 liters of urine in a 24-hour period of time. Anuria is that urine output of less than 100 mils in 24 hours. Anything less than 50 is considered renal failure and is not compatible. So dialysis would have to be done to get rid of those toxins. Nocturia is that excessive urination at night, getting up and going more than one time in the night. Hematuria is having blood in the urine. Residual urine is that urine that's just left in the bladder after we have voided. So patients maybe with prostate problems, this may block some of that urethra and the urine is not allowed to come out. They may void 200 mils, lay back in bed, and we bladder scan them and see an additional 200 mils in them. And that's that residual urine. Voiding is just the act of urinating. And Kegel exercises are those pelvic muscle exercises that we can treat if we have any leakage or urge incontinence. So let's talk about some alterations in our urinary elimination. We can talk about urinary retention, urinary tract infection, urinary incontinence, or urinary diversion. Urinary retention, this is when the kidneys are working just fine, but the bladder has that inability to empty. It's that constant feeling of needing to go to the bathroom. Patients may go 2 to 3 times an hour without much relief, and it's a very unsteady flow. Urinary tract infection is mostly caused by E. coli, bacteria that spreads in that ureter or bladder. This is not an infection typically of the kidney. If it does go to the kidney, then it is called pyelonephritis. So UTIs are within that urinary system, but it typically doesn't include that kidney. Very uncomfortable feelings, burning with urination. Women are more susceptible because of that short urethra that they have and the proximity of the meatus opening to that anus. Urinary incontinence is that involuntary leaking of urine, and we're going to talk quite a bit about that in a minute. And then urinary diversion, and we're also going to look at this closer really in lab. But this is when a patient has an issue with the bladder. Maybe they have bladder cancer, and we're going to create an external opening for them to be able to excrete their urine. So when we think about our older adults, we need to make sure we're giving them frequent opportunities because they do have smaller bladder capacity. We want to make sure they're completely emptying the bladder before and after meals. Urinary stasis can increase infection, decrease that consumption of caffeine, so coffee, teas, and sodas, because that is a diuretic effect that can make it hard to get to the bathroom on time. Alcohol can also have that same effect. We want to encourage our older adults to drink fluids that increase the acidity of the urine. So cranberry juice, drinks that might be high in vitamin C. This is really going to help decrease that susceptibility of bladder infection. We never want to decrease the amount of fluid intake for the older adult unless there is a medical condition. We need to continue to encourage that 2.5 to 3 liters of fluid a day. Drinking less fluid can cause other problems with our older population. We also want our patient to understand that incontinence is not a normal part of aging. The increased risk is there, but it's not normal, and typically we can do something for it. Let's intervene and let's help them. So why do patients have some diversionary systems? Typically bladder cancer, radiation, maybe there's an injury to the bladder, or they've just had lots of chronic infections. So we need to necessitate a diversionary system to drain that urine in a different way safely. Continent diversions have a reservoir. This can be created with a distal pouch of the bowel. They take a piece of that bowel and they turn it into a pouch, kind of like a fake bladder. Then the ureters are embedded into that reservoir. The reservoir is placed under the abdominal wall, and then a narrow piece of that ureter comes to the outside of the abdominal wall to form a stoma. Then we create a valve so that that patient can drop a catheter into that pouch. So this is considered a continent because the patient controls when they go to the bathroom. It is only emptied with the patient when the patient drops the catheter into the stoma. And they're going to do this about 4 to 6 times a day for the rest of their lives. They go to the bathroom, they drain the pouch, they go out, and they go on with their day. The other type of urinary diversion is our incontinent diversion. And these patients do not have that reservoir. It's connected directly to the ureters. The urine drains out of the abdominal wall into an external pouch. These are not as common because they're not as convenient for our patients. Patients that may not have enough bowel to make the pouch may have to have this option because it's really the only option that they have. So that urine drains continuously without any control of sensation when it's coming out. So when we think about our physical assessment, we're starting our nursing process here. An assessment is our first part of our nursing process. This is where we can use our knowledge and experience and use our nursing process, right? The first step is assessment and gathering information about that normal urine pattern, the symptoms they're having, what is affecting them. This is the subjective information that you're gathering. Then we'll do our physical assessment of our patient and get that objective data. We will look at the urine characteristics and run a urinalysis and interpret those results. We will ask them about their perception of the problem. What do they think is going on? And then we also need to gather more information about that self-concept and maybe their sexuality. So here are some different systems that we're going to want to assess. We're going to assess the skin. The urinary system and the integumentary system are two different systems, but they play really well together. We want to assess for hydration by looking at their turgor. Pinch over that bony area. If it tense, then we may have a concern with hydration or dehydration. We also want to look at their mucous membranes. Look at their mouth. Is it dry and tacky, or is it really well hydrated? We want to assess the bladder for any distension, assess the kidneys. We can roll the patient on their side or turn around and percuss that kidney area for any discomfort. We can assess the urethral meatus, that opening at that urinary system, and we're looking for discharge, inflammation, lesions, what could be the source of their discomfort. You may also be thinking this is a urinary issue, and then when we do the examination, we find a sexually transmitted disease that is actually causing that large amount of discharge or inflammation. So as we still are working on our assessment, now we're going to assess the urine. We've collected a sample, and now we're going to look at it. We will look at the color of the urine. It should be pale straw to an amber color. Pale straw to amber are your normal colors. Anything outside those colors would be considered abnormal, and we would need to investigate further. Urine will be more concentrated in the morning, and medications and some foods can change that color. So if we have an abnormal color to the urine, we probably need to keep assessing. Clarity is another characteristic we want to look at. Can you see through it? If you can't or you see little floaties, then something's going on. We also want to assess odor. You will notice if there's a smell pretty quickly. Normal urine will have a little bit of an ammonia smell to it, but it really should have a very small smell. A sweet, fruity smell may indicate some type of diabetes or starvation. So we are looking for that obvious odor. Then we'll do some testing. So how are we going to get that urine in a cup? When we're ready to collect it, we can collect it for several different tests. We can do a random, non-sterile specimen, a clean catch urine, and we'll explain that procedure. We've done our best to clean the cleanest specimen, but this is not sterile. The only way to get a sterile specimen is through a catheter. This could be a quick in and out catheter or an indwelling catheter. And then that last one is a timed urine specimen. This is a large jug, and you send it to the patient to the bathroom right now. Patient's going to void in the hat, and then we discard that one. That one has been sitting in the bladder for 2 to 4 hours, right? We don't want that one, and we want to start the timer then. So every time they urinate, we will collect it in the hat and dump it into the jug. The jug will stay in an ice bath in that bathroom, and we'll collect it for 24 hours. We do one more void at that 24-hour mark, and we send it to the lab. So why do we do this? This 24-hour urine tells us a lot about some of the systems of their body. If we do a one-time urine, it's going to give us a quick picture, where that 24 hours is going to give us a bigger picture. So we did talk a little bit about medications and how do they affect our urine. So you can see there medication factors. Why would we be taking medications? And there's some factors listed above there. But really what I want to talk about is that color of that urine. So some of the medications can change the color of the urine, which is definitely going to change your specimen outcome. So pyridium, which is given for urinary tract analgesic for that discomfort, is really going to change the urine from an orange to an orange-red urine. Amitriptyline, is an antidepressant, and it's going to have that blue-green urine. Levodopa, or for anti-Parkinson's, is going to give you that brown or black urine. And then riboflavin is going to make it a very bright yellow. So just know that medications do affect our urine, and then it's going to affect our specimen collection. So again, this is just a recap of our 24-hour urine. First thing in the morning, they're going to empty that bladder. We're going to throw that urine away, and we're going to start that timer. We're going to write down that time that you emptied the bladder on the collection bottle, and this is the start. The next time you need to go, we're going to collect that urine in that hat. We're going to put it into our jug. We're going to keep our jug on ice in the bathroom, and we're going to save all of our urine for the next 24 hours. At that 24-hour mark, we're going to pee one more time, dump that into the jug, and that jug goes off to the lab. Lots of non-invasive and invasive diagnostics that we can look at. We'll look at that urinalysis first. So when we look at our urinalysis, we've collected our sample, we've sent it to the lab. Now the lab is looking at the urine and sending me back the information. They're going to send me back that specific gravity. So we're going to compare specific gravity to water. So what is the concentration of the urine compared to water? A high specific gravity means the urine's very concentrated compared to water. That's not really normal. So dehydration, renal failure could be considered. Then we look at the pH balance. An acidic urine will protect us from infection. Those that have alkaline urine may struggle with that protection. Protein is an indicator of renal disease. Protein should filter out through the kidneys, and if there is a filtration problem, then there's going to be a protein buildup in that urine, and we don't like proteins in our urine. Glucose in the urine is not normal. It usually indicates some type of high blood sugar. A blood sugar typically greater than 300 is going to start spilling glucose into the urine. Ketones are similar to glucose. You'll see ketones with that patient that has really high blood sugar, usually greater than 500 at this point. Very dehydrated patients will also spill ketones. So think about our patient that has a starvation diet. That ketogenic diet is the one that comes to mind. And if you're not doing that keto diet well, you will have ketones that spill into your urine. The presence of blood, also not normal. Any blood means something is wrong, so maybe kidney stones. If a woman is on her menstrual cycle, you may see blood, so we can never collect a clean specimen if that's occurring. And the last thing the urinalysis is going to tell us is there any WBCs or leukocytes in my urine? WBCs in the urine system will tell us if there is some type of an infection going on. There shouldn't be any, and if there are, then we need to check for more signs and symptoms of infection. So culture is really the same urine specimen that we send to the lab. We're going to send it for culture, and that's going to really allow for the lab to see what bacteria is growing and then send that back to you with what medications would help kill that bacteria. The culture does take about 48 to 72 hours. So sometimes we'll start an antibiotic initially. If it's not the right one, then we can switch it when the right one comes back. Renal ultrasound is a scan of the kidney. It can also be called a KUB. It's a very non-invasive diagnostic test. Bedside sonography or bladder scan can help detect any residual urine if the patient is having urinary retention, which may be a bladder concern versus using a bladder scanner may not be finding any residual urine, may indicate a kidney issue. Radiography, we've talked about that KUB. More invasive procedures will include sending tubes or cameras up in the area to look around, and that's just going to give us a better picture of whatever problem may be going on. So why do we measure INO, or intake and output? It really gives us great information. Our 24-hour input and output should be essentially the same. If you drink 2.5 liters, you should put out 2.5 liters. Some output we may not be able to measure though. Respirations, perspiration, right? That's just fluid that we are putting out, but difficult to measure. Concerns happen when we drink 800, but we put out 2,500, or vice versa, if we take in 2,500 and only put out 800. So how do we measure? We can use a hat, we can use a urinal. We need to have them measure every time they urinate. And we can make sure that we delegate that task to our care assistant. We want to measure everything possible. When we think about our intake, everything they drink, anything that they eat that could be liquid in a room temperature, we want to make sure we're measuring. So ice cream, jello, popsicles, we want to make sure we're measuring that as intake. When we think about output, anything that comes out of their body. So if we have a nasogastric tube to suction, we want to measure that. If they vomit or have emesis, we want to measure that. If they have any wound drainage, we need to measure that. Chest wound drainage, we need to measure that. When do we measure? Anytime anything is full. So if their hat is full of urine, we need to measure it. Urinal, chest drainage, tubing is full, we need to measure that. So we want to look at the whole every 24 hours. What is the patient's responsibility in this? It really kind of depends on that patient's status. If they can get up and go into the hat, then they can tell you how much urine should they produce. Again, that's very individualized. We get really concerned if the patients don't produce less than 30 mils an hour for a couple of hours. This is the least amount you need to get rid of the waste in your body. So these are different devices that we can use to collect urine. That far left one is your Foley catheter. The middle one there are your bedpans, your urinals, and then that far right one is your hat, dumping it into a measuring container, and then maybe putting it in a specimen collection if you need to send that, or you can measure it and then dump it in your toilet. All right, so let's talk about Foley catheters and the reasons why we would need to use a urinary catheterization. Foley catheters increase our risk of infection and potentially harmful outcomes. Patients that may be incontinent would negatively be impacted by a catheter. So as the nurse, if you're having a patient with a catheter that is incontinent, we need to find a way to get that out. So this slide tells us the reasons why a patient might need a catheter, okay? Retention is a big one. If the patient has an enlarged prostate and they are unable to fully empty their bladder, that urine will become stagnant and can cause an infection if we don't get that urine out. Catheterization can give you a sterile specimen. Patients that have surgery need lots of fluids before that surgical procedure, so catheterization will be warranted, especially if they have any anesthesia. Critically ill patients, especially those with head injuries, it can cause diabetes insipidus, which can be an increase in fluid overload. So we would probably want to cath those patients. And our terminally ill patients require comfort. Catheterization may help with them with this comfort. As we look at this list, it's a very short list, which just again tells us that catheterization is a very invasive, high-risk procedure that we really only want to use when absolutely necessary. So when we're talking specifically about catheterization, there's a couple of different ways we can do this. When we're thinking about an intermittent technique, you can introduce a straight single-use catheter long enough to drain the bladder, so 5 to 10 minutes. When that bladder is empty, you immediately withdraw that catheter and you can repeat that intermittently. It is common for people with spinal cord injury or other neurological problems such as multiple sclerosis to perform this self-intermittent catheterization, usually up to about 4 hours daily for months or even years. An indwelling or Foley catheter remains in place for a longer period until the patient is able to void voluntarily or until continuous accurate urine measurements are no longer needed. So catheterization insertion is done using sterile technique. We will have that opportunity in lab this week. Remember, this is a closed drainage system, so it's sterile, meaning that entire system is not interrupted to introduce any bacteria. There's a small opening at the very bottom of the bag that the urine can be emptied. When we think about catheter care, you have to provide catheter care at least 3 times a day. Perineal care plus cleaning of the catheter, clean gloves, soap and water, washcloth, and cleaning that catheter from the meatus down towards the bag, right? Dirty to clean. You don't want to clean up because then you're putting that patient at risk for bacteria. Most of the tubing is made with a silver lining, so that bacteria is harder to collect on that tubing. When we think about fluid intake, remembering our patient needs to drink about 2.5 to 3 liters a day to flush out that bladder. So keep that fluid moving to keep it from becoming stagnant. Catheter irrigation is a 3rd lumen on the catheter equipment for irrigation. We can irrigate with a sterile solution. And then removal of catheter with clean gloves, deflate the balloon, pull the catheter out. If you can find an alternative to a catheter, then you should advocate for that alternative for your patient. Not always an option, but if it is, we need to seek it and we need to use it. So these are different types of catheters. The biggest takeaway from this slide is that bottom catheter is a double lumen, one for urine drainage and one for that balloon inflation. You cannot obtain urine from the 2nd lumen that you are filling the balloon. So just be aware of that. I've had students try to pull back from that 2nd lumen and all they're doing is taking the water out of the balloon and then the catheter falls out. Rule of thumb, when you hang that collection bag, You must hang it below the level of the bladder. If you don't, the urine's going to stay stagnant in that tubing and the bladder and will have increased risk of infection. Here is one of the alternatives to catheter insertion that works great for men. It's a condom catheter or Texas Cath, which is just that brand name. And it goes over the penis and collects the urine. Needs to be changed about every 24 hours, and make sure you do great perineal care and then place a new one on. This is not useful for retention, but can be helpful with incontinence because it keeps that urine off the patient's skin, making sure that the tip of the penis is at the end of that catheter. If there is any space noted between the end of the penis and the catheter, that's where that urine's going to pool, and it could excoriate the end of that penis. Leg bag is attached to that condom catheter. It's a much smaller bag than the Foley catheter bag, so it may need to be changed more frequently. It can be secured to the leg. They can put their pants on and they can move around, and it's just a much safer option. So we've talked a little bit about urinary tract infections, remembering that this is an infection of the urinary tract, not of the kidneys. If it's the kidneys, then it's something else. The most common bacteria is E. coli. Clinical manifestations are going to include frequency, urgency, nocturia, flank pain, hematuria, cloudy urine, foul-smelling urine, and potentially fever. In older adults, it could make them very confused, incontinent, anorexic, and fever. So if you see some new onset incontinence in our older adults, we need to start thinking about that urinary tract infection. And our nursing actions are just going to make sure we're cleansing our female from front to back, beneath the foreskin in our males. So who are our patients at risk for UTIs? Women that are sexually active. Remember, they have that very short urethra. So if they're sexually active, after any sexual activity, you should urinate to rid some of that semen out to not cause bacteria. Women who use diaphragms for contraceptive, postmenopausal women, individuals with indwelling urinary catheters. We've talked about that quite a bit. If you have diabetes, you're going to be at more risk for those UTIs, and then our elderly population as well. So let's move into some incontinence and the care for our patients. What are the struggles with incontinence, and how can we implement some solutions for our patients? This slide talks about some of those solutions that we can provide. Patients with stress or urge incontinence have a difficult time starting and stopping the flow of urination, and they can really benefit with exercises that strengthen that pelvic floor. So Kegel exercises should be educated. It's important, and there's a video there if you want to take a peek at that. Important takeaways from that video. It does take about 8 weeks for this to start working. They have to do multiple sets per day, usually about 100 per day. Bladder retraining is another one that we can implement, and that just reduces that voiding frequency and bladder capacity. We're going to take that patient to the bathroom every 2 hours to prevent that bladder from stretching out, and that decreases our dribbling that may be occurring. Habit training is a functional incontinence will benefit habit and develop a pattern that fits into their life. Self-catheterization, maintenance of skin integrity can be a problem with urinary incontinence. Acidity of that urine can excoriate the skin. Frequent changes need to occur. So promoting comfort for our patients just really increases that confidence. So types of urinary incontinence, we've talked a little bit about some of these. Stress is that increased leakage of urine due to increased intra-abdominal pressure. So you sneeze, you laugh, you cough, you urinate just a little bit. It's because of that increased intra-abdominal pressure. Urge incontinence is having that urgency with bladder spasm. Does not have anything to do with how much urine is in the bladder. The bladder can be empty, and those spasms can cause some incontinence. Mixed is a little bit of both. Overflow, urinary retention, is that bladder is over distended. The bladder is leaking because they cannot completely empty the bladder, so maybe some type of obstruction might be happening. Functional incontinence is that urge to void that causes a loss of urine before reaching the bathroom. So maybe there's an environmental barrier, right? There's no toilet. Maybe there's physical limitations. You have trouble getting to the toilet, or maybe you're confused or disoriented. Reflex incontinence is involuntary or moderate amount of urine. There's no warning. Hyperreflexia of bladder happens, and there's just no warning for that. And then total incontinence is unpredictable. It's not generally responsive to any type of treatment, unfortunately. So how do we treat our incontinence? We can look at functional and stress. For functional, we can schedule toileting times, right? We take them to the toilet every couple of hours. We can use absorbent products, so maybe a little panty liner, things like that to help absorb any leaking. We can limit their fluid 2 hours before bedtime, so pushing lots of fluids during the day and then limiting that evening fluid. And then we want to definitely protect the skin, apply barrier type creams. For our stress incontinence treatment, we just need to decrease that intra-abdominal pressure. So encourage weight loss, avoid heavy lifting, and then doing those pelvic muscle exercises or those Kegel exercises. So we've done all of our assessment. We're thinking about our analysis. What are some of our concerns? Incontinence, pattern alteration, urinary retention, anxiety, caregiver role strain, risk for infection can all be great analysis based off of our assessment. So what are some of the goals? We want to make sure that our patient's producing enough quantity of urine to maintain fluid, electrolyte, and acid-base balance. We want to make sure our patient is emptying their bladder completely at regular intervals without any discomfort. We want to provide care for our urinary diversions and know when to notify our physician. Are we seeing any signs and symptoms of infection? Or are they having retention? What's going on? When do we need to notify that physician? We want to develop a plan to modify those factors contributing to current or future urinary problems and correct any unhealthy urinary habits. And then how did our patient do? We want to evaluate those goals. Did they meet those outcomes? Make sure we're checking in with our patient and their progress that they've made. Help the patient redefine those goals if we need to. If something's not working, we need to go back and reanalyze, and then revise our nursing interventions as indicated. And that concludes our urinary elimination chapter. If you have any questions, you can shoot me an email or we can chat about it in class. Thanks, guys.